Welcome to the lecture on antivirals and antiprotozoals. This is Phyllis Dumont, spring 2018. Acyclovir was approved by the FDA in 1982 and was one of the first antiviral medications. It is a nucleoside analog, so it's a structural analog of deoxyguanosine. The mechanism of selected toxicity, the compound is phosphorylated by viral thymidine kinase, and then it has preferential incorporation by viral DNA polymerase, and this causes the chain to terminate. It has about 20% oral bioavailability. An advantage of valacyclovir is that it's 3 to 5 times more bioavailable. It does penetrate the CSF, and it's effective in treating primary herpes infections, including genital encephalitis and neonatal infections. It's used in the management of chronic herpes, but it does not cure. However, it can reduce the incidence of recurrences. Acyclovir is a prototypical antiviral drug, a purine analog, and it requires activation by the viral thymidine kinase to inhibit DNA polymerase and block replication. The DNA polymerase of herpes viruses differ in their degree of sensitivity to acyclovir, ranging from herpes, which is the most sensitive, next to varicella, next to cytomegalovirus, with Epstein-Barr virus being the least sensitive to acyclovir. For all of the antivirals, they have a narrow spectrum of activity. They inhibit replication, but they don't outright kill the virus. And most of them target specific proteins, usually an enzyme involved in nucleic acid synthesis. The treatment of herpes simplex virus recurrent infections now involves chronic therapy with acyclovir, valacyclovir, or famciclovir. These are modestly effective in reducing the number of outbreaks. On the horizon are some therapeutic vaccines using herpes simplex virus 2 surface protein GD2. This has shown a 30% reduced recurrence. However, the research has not moved rapidly. Acyclovir is useful for cytomegalovirus, varicella zoster. It's similar to acyclovir. It has 6 to 9% oral bioavailability and penetrates the CSF. It's more active than acyclovir against cytomegalovirus. It has some additional toxicity, including bone marrow suppression and CNS disruption, headaches, convulsions, and psychosis. And about 40% of patients will see some toxic effects. Treatment principles with these medications consider patient variables. Among the elderly, they're more likely to have renal or CNS events with anti-herpes meds, so we use lower doses. For folks over age 65, we reduce the doses of amantadine and rimantadine. No dosage adjustment is necessary with the anti-flu medications, zanamivir or oseltamivir. Metronidazole, we consider lowering the doses in the elderly. For pregnancy and lactation, famciclovir, valacyclovir, and metronidazole are category B. Acyclovir, amantadine, rimantadine, and zanamivir are category C. Chloroquine is not rated but should only be used if the potential benefits clearly outweigh the potential risks. Use of all of these drugs is not recommended while breastfeeding. Famciclovir has off-label use for the treatment of chickenpox in immunocompetent kids greater than 2 years old. Amantadine and rimantadine, their safety and efficacy has not been established in kids less than 12 months old. Zanamivir, flu A and B prophylaxis for household contacts is approved for 5 and up. For community outbreaks is approved for 7 and up. For treatment is approved for 12 and up. Oseltamivir, treatment approved for greater than 2 weeks old, with prophylaxis approved for greater than 1 year old. Metronidazole, the safety and efficacy has not been established in kids except for amoebiasis. And chloroquine is quite toxic in accidental overdose, and this needs to be held in mind when talking to parents or adults about keeping the medication out of the reach of kids. The anti-influenza viral drugs, amantadine and rimantadine, were first. They're only active against influenza A. Their mode of action is that they block the influenza M2 ion channel on endosomes and prevent the passage of hydrogen ions required for acidification and viral uncoating. These tend to have mild CNS effects, which should not be surprising since amantadine was initially used as an anti-Parkinson medication. Zanamivir and oseltamivir are active against both influenza A and influenza B, so that's an advantage. They inhibit influenza viral neuraminidase. Neuraminidase must cleave terminal sialic acid residues on receptors recognized by viral hemagglutinin. Without this cleavage, the virus remains trapped on infected cells, which is sitting on the surface of the cell, and they can't release their infectious particles into the cell. Zanamivir and zanamivir are chemically related. They do have different routes of administration. Oseltamivir is a tablet or suspension, and zanamivir is an orally inhaled powder. And the mechanism of action, again, they block active sites of neuraminidase. They reduce the amount of viral particles released from infected cells, and this leads to decreased shedding of influenza A and influenza B viruses. This is very useful in settings such as a nursing home where you want to try to halt an outbreak of influenza A or B. Oseltamivir is metabolized by the liver and excreted in urine. Adverse effects include GI disturbance, and it does require a dosage reduction with kidney disease. I'm going to talk a little bit about antivirals and their use for Hep C and the new rationale for integrating Hep C treatment into primary care. We are entering an era where we have very effective brief oral regimens available for all Hep C genotypes. Some are as simple as 1 pill a day. Pegylated interferon, a drug which had to be administered IV and had many unpleasant side effects, is seldom needed. The new medications are highly effective, well tolerated, and short treatment duration. And if improved access is going to occur, the number of providers who are available and willing and able to treat Hep C needs to increase. Transmission, the most effective way to transmit Hep C is through injection drug use. That's the most common means of transmission in the U.S. About 33% of IV drug users, 18 to 30, are infected. And the number rises to 70 to 90% of older IV drug users. Treatment recommendations change quickly. Therefore, it is very important that you seek the most current information. And for that reason, we're not going to spend a lot of time on the actual treatment options. But I urge you to review guidance on the website hcvguidelines.org for the latest recommendations and to check the CDC website as well. So the role of primary care is Hep C screening, risk-based, and a one-time birth cohort screening for baby boomers for hepatitis C virus antibody. Confirmation of HCV infection requires HCV RNA testing. Counseling to prevent transmission, and regarding the use of risk of alcohol for folks who are HC positive. Screening in Hep C infected individuals. Also, it has to extend to HIV, hepatitis A, and hepatitis B, since their transmission routes are the same. And alcohol and substance use disorders are common in this population. Primary care also has a big role in vaccination against Hep A and B. There is no vaccination for Hep C. Baseline liver assessment and treatment and referral, because patients need to be informed of the current effective, well-tolerated treatments and referred to a provider with expertise. The cost is prohibitive. There are a lot of different ways to get treatment, and it is important, just as it is with HIV treatment, that the patient be in a situation where starting the medication and being able to stay on it and complete the prescribed duration of therapy is very important. Okay, moving on to the antiprotozoals. Metronidazole is a synthetic nitroimidazole antibiotic derived from azomycin. It was first found to be active against protozoa and then against anaerobes, where it is still extremely useful. It's used in the treatment of C. difficile, among other things. Antiprotozoals, it's cytotoxic, but the mechanism is not well understood. It's thought to damage DNA synthesis, which leads to cell death. And many of the antiparasite drugs used in the treatment of malaria increase the internal pH of the parasites, which also leads to death. Metronidazole spectrum of activity with anaerobes, you can see the list there from Helicobacter pylori through Bacteroides. Anaerobes, Trichomonas vaginalis, Entamoeba histolytica, Giardia lamblia, and Gardnerella vaginalis. Side effects from metronidazole include gastrointestinal disturbances, nausea, vomiting, stomatitis, and a metallic taste in the mouth. The CNS and the most serious side effects, peripheral neuropathy, seizures, and encephalopathy can occur. It should be used in caution in patients with pre-existing CNS disorders. And the emergence of CNS side effects requires discontinuation of metronidazole. And there are also unanswered questions about mutagenicity and carcinogenicity. There are a lot of drug interactions. Several are listed here. Be aware of them. Now we're going to talk a bit about antimalarial drugs. Malaria is a huge burden worldwide, and there is a growing number of medications available to treat it, but we don't have a single medication that is able to deal with the parasite at all of its stages of development. But most antimalarial drugs inhibit growth by concentrating within the acid vesicles of the parasite. They increase the internal pH of the organism. They also inhibit hemoglobin utilization and parasite metabolism. Phosphate, or Arelin, is an effective drug against P. vivax, P. ovale, P. malaria, and drug-sensitive P. falciparum. It can be used for either prophylaxis or treatment, and this is a prophylactic drug of choice for people traveling to an area of the country where malaria is sensitive to Arelin. Quinine, or qualaquin, is used for malaria treatment only. It has no role in prophylaxis. It must be used with a second agent in drug-resistant P. falciparum. For drug-resistant parasites, the second agent is often doxycycline, tetracycline, pyrimethamine sulfadiol, or clindamycin. Quinagluconate is indicated for severe or complicated malaria, and it is used in conjunction with doxycycline, tetracycline, or clindamycin. It can be administered IV, and it's the only parentally available quinine derivative in the United States. And is used for malarial prophylaxis or treatment. If used for P. falciparum malaria, this drug must be used as part of combo therapy, typically with quinine or quinidine. Tetracycline may specifically impair the progeny of apicoplast genes, resulting in their abnormal cell division. The loss of apicoplast function in the progeny of treated parasites leads to slow but potent antimalarial effect. Clindamycin is part of combo therapy for drug-resistant malaria, typically with quinine or quinidine. It is a good second agent for pregnant patients. Mefloquine may act by raising intravesicular pH within the parasite's acid vesicles. It's structurally similar to quinine, and it's used for the prophylaxis or treatment of drug-resistant malaria. It may cause adverse neuropsychiatric reactions. Don't use in patients with active or recent history of major depressive disorder, generalized anxiety disorder, psychosis, or other major psychiatric disorders. And that's notable distinction between mefloquine and some of the other drugs we're talking about, so it would be a good thing to remember. Novaquone and proguanil, which is a combination found in a brand name Malarone, may inhibit metabolic enzymes, which in turn inhibit the growth of microorganisms. This drug is used in peds. This particular combo is used for uncomplicated P. falciparum. It can also be used in combination with chloroquine. It's approved in U.S. for prophylaxis and treatment of mild chloroquine-resistant malaria. It's a good prophylactic option for patients visiting areas with chloroquine-resistant malaria who cannot tolerate mifloquine. Primaquine is not used to treat erythrocytic stage of malaria. It's used for the hypnozoite stage of P. vivax and P. ovale to prevent relapse in patients.